I can't hear any voice.
Hello, Dr. Sudeep sir. My voice is clear? Hello, Dr. Sudeep. My voice is clear? Hello, Dr. Sandeep.
Yeah, yeah.
Yeah,
I
my
can-
voice is clear, sir.
Yes, sir. Absolutely.
Yeah.
Sir.
Okay. Actually, I was just asking. No, there is no sound. I just want to
Yeah,
hear.
yeah. I was not having any sound. Now I have. Thank
Okay.
you.
Okay. Thank you.
Yeah. Thank you, sir.
Warm good evening to one and all. Today we have gathered here for the online Navigate Medical CME program by NAMS. And today's session is on autoimmune liver diseases. And moving ahead, I would like to welcome Dr. Umesh Kabel sir, the Secretary of NAMS, to kindly deliver the welcome address. Please, sir.
Well, on behalf of the Secretary NAMS, it is my great privilege to welcome the speaker as well as the participant and the chairperson for this session. As you know, this session is last in the series of 6 lectures which we had on liver problems. And I hope that this present lecture again will be very, very useful for our participants. So once again, I welcome all the participants esteemed speaker and the chairperson to this particular session.
Thank you, Sud sir. We have with us Professor Ashish Goyal sir, the head of the Department of Hepatology, CMC Vellore. Sir has special interest in autoimmune liver disease, which is the main topic for today, and again in liver transplantation and hepatocellular carcinoma. Sir has more than 200 publications and has authored various books. So I request sir to kindly provide the opening remarks as well as to introduce the speaker for this session. Please, sir.
Thank you. Thank you to the NAMS at the outset for this opportunity. And I welcome all the participants to make the best use of the training session today. And we have Dr. Sunil Taneja, who is going to deliver his talk on autoimmune liver disease. As a member of the hepatology communities, will all know that who Dr. Sunil Taneja is, and he needs no introduction for that society. He is member of various national and international societies, extensively published and expert in liver diseases with special interest in autoimmune liver disease. I think we need a speaker like him to deliver a talk on a clinical, a very relevant topic of autoimmune liver disease. And let us, with no further ado, listen to Dr. Sunil Taneja speak on this topic.
Good evening, everyone. Thank you, Dr. Ashish, for your kind introduction, and thank you, NAMS, for giving me this opportunity. Am I audible, and are my slides visible?
Yes,
Am I audible?
Yes,
yes sir, you are audible.
Okay. So the topic for today is autoimmune liver disease, and I'm going to give you a brief overview of autoimmune liver disease. And primarily, I'm going to discuss autoimmune hepatitis, the clinical part, the diagnosis, and the management. The spectrum of autoimmune liver disease consists of autoimmune hepatitis, primary biliary cirrhosis, primary sclerosing cholangitis, and then you have an overlap syndrome. So overlap of either AIH with PBC, AIH with PSC, and then you have certain cholestatic variants which would not fall in either of the category. So what is autoimmune hepatitis? Autoimmune hepatitis is a complex heterogeneous disease, and this can start as early in childhood, but can also manifest in the 7th or 8th decade of life. And it is characterized by hypergammaglobulinemia, certain characteristic autoantibodies, certain HLA antigens, which are HLA DR3 and DR4, interface hepatitis on histological examination. This is one of the hallmarks on if you do a biopsy in patient with autoimmune hepatitis. And one of the criteria is an adequate response to immunosuppression. So once you diagnose patients with autoimmune hepatitis, you tend to give them immunosuppression in the form of steroids and azathioprine. And if there's an appropriate response, then also it is considered that it is, because it is an autoimmune disease, they respond to immunosuppression. Okay, so let's look at the epidemiology of this disease. The AIH manifestations vary by race and ethnicity. Alaskan natives have a high frequency of icteric AIH. Hispanics more commonly present with cirrhosis. African Americans have accelerated progression of disease and higher rates of recurrence after liver transplant. There is a female preponderance in this disease and is seen in both children and adults. The age of onset peaks around 10 to 30 years, and the second peak is seen at 40 to 60 years of age. The estimated incidence of AIH varies worldwide, and the reported incidence rates in adults range from 0.67 to 2 cases per 100,000 persons per year. Pediatric incidences are lower, ranging from 0.23 to 0.4 per 100,000 person years. And the prevalence is in adults, it ranges from 4 to 42.9 per 100,000 persons, and in children, it ranges from 2.4 to 3 per 100,000 persons. So let's look at the data from India. This clinical syndrome has been described from a lot of centers in India. This first study came from Dr. Sarin's group, and out of all autoimmune liver disease, the prevalence of AIH was around 3.43%. The second series was from Dr. Chaudhary's group from SCPG Lucknow, and they reported an overall prevalence of 1.7%. And subsequent to this, in 2015, Dr. Amarpurkar from Mumbai reported this prevalence of around 5.7%. So let's look at this data a little closely. This is the first paper published on autoimmune liver disease way back in 2001 by Dr. Sarin's group. Out of 1358 liver disease patients, 39 were diagnosed as autoimmune hepatitis. And autoantibodies, asthma or ANA was positive in 80%. Type 1 AH was diagnosed in 80%. Unclassified, where both autoantibodies were negative, was seen in around 20%. There was a high prevalence of cirrhosis in this study, and varices was seen in 63%. And 15% of the patients presented with varicose bleeds. So that means that a lot of these patients presented with advanced liver disease. The overall mortality in this cohort was 25% during a mean follow-up 15 to 17 months. So let's look at the presentation in the study. The predominant presentation was jaundice, 83%, fatigue, 83%. 50% of the patients had fever, and 15% presented with complications of cirrhosis, that is hepatic encephalopathy. Splenomegaly was seen in 60%, hepatomegaly in 43%, and ascites in 43%. Let's look at the mean age of presentation. Mean age of presentation was 30 years. Obviously, male to female ratio. Females have more preponderance of this disease, 3:1, and duration of symptoms around 18 months. As I said earlier, cirrhosis was seen in majority of these patients, and 76% of these patients were diagnosed late and had cirrhosis at presentation. Let's look at the second data. This was published in 2005 from SCPGI and Dr. Chaudhry's group. Out of 2,400 liver disease patients screened, 41 patients were diagnosed with autoimmune hepatitis, AIH in 38, and primary biliary cirrhosis in 3 patients. Autoantibodies, SMA in 24, ANA in 15, both SMA and ANA in 4 patients. Small proportion of patients had primary biliary cirrhosis, and rheumatoid factor was positive in 5%, P-ANCA in 5%, and LKM was negative in all these patients. 1 death was reported during follow-up, and this patient developed pulmonary tuberculosis and developed ATT-induced ALF. So let's look at these characteristics. Again, the mean age of presentation was around 36. Female preponderance, duration of symptoms 20 months. 50% had chronic hepatitis and 34% had cirrhosis. So again, the advanced chronic liver disease is seen in majority of patients who are diagnosed with autoimmune hepatitis. So tune of 70-80%. Acute hepatitis in a small proportion of patients, and cholestatic hepatitis in 1 patient. Similar presentation as the previous study, majority presented with jaundice, fatigue, complications of cirrhosis like edema and encephalopathy. Majority had hepatosplenomegaly, and few patients had ascites. Autoimmune liver disease, diseases like vitiligo was seen in around 10% of patients. And then came this data from Mumbai, 2015, Dr. Amarpurkar's group. So out of 14,000 patients, 181 patients qualified for the diagnosis of autoimmune hepatitis, and 125 patients had substantial follow-up in this study. 65 patients had definite AIH, 81 were females, median age of presentation was slightly higher, 46, and prevalence of AIH was overall 1.3% of the total population, and 8.74% amongst all liver disease patients. Type 1 autoimmune hepatitis is more common, 89%, and type 2 was seen in 14. Autoimmune negative, that means autoimmune markers negative, in which the antibodies are negative, was seen in 22%. After a median follow-up of 7 years, 15 patients died, 12 because of liver-related complications, and 2 underwent liver transplantation. Now let's look at the presentation. Chronic hepatitis and cirrhosis is the predominant presentation again here. Cirrhosis in 31%, chronic hepatitis in 14%. Acute hepatitis was seen in 6.4%. In this group, a lot of patients had decompensated cirrhosis, so even more advanced as compared to the other studies. ACLF, which is acute or chronic liver failure, was seen in 7.2%, and around 2% patients were asymptomatic and were picked up on investigations only. So let's now look at the clinical manifestations of this disease. AIH can present in varied forms. The patients can be asymptomatic, symptomatic in the form of acute hepatitis or chronic hepatitis, and there's a special group, pregnancy and elderly, which I will discuss, because they need special care if they are diagnosed with autoimmune hepatitis. So let's look at this presentation a little closely. As I said earlier, they can be symptomatic or asymptomatic. The acute presentation is seen in around 25 to 30%. In this acute presentation, either they can be icteric hepatitis or they can present with severe acute hepatitis in which the INR is prolonged, but they do not have encephalopathy. So jaundice and coagulopathy, but no encephalopathy. A small proportion of patients can present with acute liver failure in which you will have jaundice, coagulopathy, and hepatic encephalopathy. So this is what is seen in acute presentation. The second group which presents acutely is the acute on chronic liver failure, in which there is an underlying chronic disease and there is an acute fear of that disease. However, majority of patients of autoimmune hepatitis just present as chronic disease, that is chronic hepatitis, in which around 30 to 40% will present with cirrhosis. The other group would be asymptomatic. Some would be symptomatic with fatigue, anorexia, generalized body aches, malaise, joint pains, etc. So let's see the clinical manifestations in detail. Chronic non-specific symptoms is most commonly seen: fatigue, malaise, arthralgias, or amenorrhea. Easy fatigability is one of the common symptoms in autoimmune hepatitis. Jaundice, which might be fluctuating, can be seen in around 50%. And physical signs are usually absent unless there is evidence of cirrhosis. Around 10 to 15% of the patients will have extrahepatic autoimmune disease like vitiligo, IBD, thyroiditis, etc. Asymptomatic presentation, 25 to 34%. Histological findings are similar to those of symptomatic patients. Histological findings are similar to those of symptomatic patients and frequently develop symptoms within 2 to 120 months. The mean interval of development of symptoms is around 32 months. Absence of symptoms should not discourage treatment, but if any patient who has laboratory evidence or histological evidence of autoimmune hepatitis, they should be treated even if they are asymptomatic. Now let's look at the other presentations. Acute severe AIH and ALF, as I said earlier, can be seen in 25%. ALF, a small proportion of patients, that is 3 to 6%. And it can be either spontaneous exacerbation or a superimposed viral toxic or a drug-induced liver injury on a previously undiscovered autoimmune hepatitis. And they usually present with acute on chronic liver failure. So this is a tabulated explanation of all the presentations. So chronic, progressive fatigue, relapsing jaundice, amenorrhea, weight loss, occasional arthralgias, or they can present with complications of portal hypertension. So 40 to 50% of total AIH would present in the chronic form. And if you do a biopsy, they will have typical biopsy findings of portal and periportal lymphocytic infiltration and interface hepatitis. The response to treatment is pretty good in this chronic group. Acute presentation, as I said earlier, 2 presentations, acute AIH or acute and chronic AIH, 25% of the whole lot. And biopsy is typical, in which you have panlobular hepatitis or bridging necrosis or confluent necrosis. And the response to immunosuppression is not very good in this, and they might require transplantation at some stage. Fulminant is rare. They have massive necrosis on liver biopsies, and they do not usually respond to immunosuppressing medication, and transplant is recommended as a treatment of choice. ACLF group is, which typically presents with jaundice, ascites, encephalopathy, prolonged INR, seen in less than 10% of the patients. And biopsy would suggest autoimmune hepatitis, can have lymphoid aggregates, steatosis, neutrophil infiltration. Some of them could have cholestasis if there's concomitant drug-induced liver injury or other injuries associated with ACLF. And they also do not really respond to steroids, and treatment of choice is transplantation. The last presentation, as I said earlier, is asymptomatic, and they usually present with abnormal LFTs, that is raised AST and ALT. And this is seen in around 20 to 25% patients. Biopsy is typically similar to chronic hepatitis. And as I said earlier, absence of symptoms should not discourage treatment. So if you have asymptomatic presentation and if you have chronic presentation, the response to treatment is pretty good. But this group, acute fulminant and ACLF, the response to medical treatment is not very good, and they might end up getting a transplant for this disease. So acute presentation, I'm trying to focus on this because 25% patients present acutely. And as I have shown you 3 series, the number of patients which were picked up as acute presentation is very less in all those 3 series. The suspicion of acute AIH is usually less in India because we tend to label most of our patients who present acutely as seronegative autoimmune, seronegative viral hepatitis. And subsequently, when they're not improving and when these patients undergo biopsy, then you label them as autoimmune hepatitis. So 2 typical presentations of AIH, which is severe and acute, includes acute hepatitis. In this, you have abruptly emergent disease of new onset, and usually the titers of IgG are low, and around 1/3 to 50% of patients will be autoantibody negative. The biopsies are typical and usually shows central lobular necrosis, no or minimal periportal hepatitis. The other group, which is more common, is the acute exacerbation, and in which there is a spontaneous flare of the pre-existing chronic disease. The clinical and biochemical features are suggestive of acute hepatitis, and in this, there is evidence of chronic hepatitis on biopsy. Now, this is the data from our institute. Out of total 150 patients, 9 patients had type 1 AIH and 7 patients had seronegative AIH. So out of the whole lot, 16 patients had evidence of acute exacerbation of autoimmune hepatitis. And all these 16 patients had AVH-like presentation. So typically what we label as acute viral hepatitis sometimes has underlying autoimmune hepatitis. Now, all these patients were treated with immunosuppression, steroids and azathioprine. 81% had complete biochemical remission and 3 patients had partial remission. 1 patient died because of complications. So look at the mean bilirubin level, median bilirubin level, it is 4.2. AST-LT is pretty high, and if you have such high values, you tend to label them as viral hepatitis. And even if they are negative for hepatitis A and E, sometimes we just label them as seronegative autoimmune hepatitis, seronegative AVH, and subsequently on follow-up, they are diagnosed with autoimmune hepatitis. The clue to diagnosis is elevated IgG levels. And when you have elevated IgG levels or you have autoantibodies positive, these patients should be closely followed up. And if they are not improving, then they should be biopsied and diagnosis of autoimmune can be established by the histology. So let's look at the Japanese proposal for acute presentation of AIH. So 3 different presentations are there. Obviously, clinical signs, they have included hepatic encephalopathy and reduction of disappearance of hepatic dullness. In the laboratory tests, AST-LT, bilirubin and prothrombin time, and in the imaging tests, hepatic atrophy and heterogeneous liver parenchymal disease. So moderate is if you have clinical laboratory tests, one of the criteria, 1, 2 or 3 or both 1 and 2. Without clinical signs, neither 1 or 2, and imaging test, neither 1 or 2. What is the severe form of AIH? In this, they should fulfill at least one of these 3 findings. Clinical signs, 1 or 2, that is presence of hepatic encephalopathy and reduction or disappearance of hepatic dullness, which suggests that the liver has become small because of the reticulin collapse. The second is clinical or laboratory tests, both 1 and 3, that is AST-LT prolonged and INR is also prolonged. So prothrombin time less than 60% or both 2 and 3, that is bilirubin elevated and INR is elevated. And imaging test 1 or 2, that means if there's hepatic atrophy and heterogeneous liver parenchymal pattern along with the clinical features. So let's look at the fulminant autoimmune hepatitis. This is a huge series from, this is from UK, and patients were diagnosed from 1986 to 2005 were included in this study. So fulminant presentation is rare, and 16 patients they could diagnose as fulminant autoimmune hepatitis in this study. 14 females, 2 males, the mean age of presentation was 36 years, and they presented with acute and severe or fulminant disease. Again, type 1 AIH was seen in 13 patients and type 2 AIH in 3 patients. 10 out of 16, that is 60% of patients presented with hepatic encephalopathy in the study. And the median INR was 5.36. And let's look at these breakup of the patients. 16 patients, 12 patients treated with steroids, only 1 patient improved 3 days after admission. Rest 10 patients required transplant. 1 patient died because of complications of sepsis. Out of the 4 patients not treated, 3 patients transplanted and 3 were alive, and 1 patient died 2 days after admission because of sepsis. So fulminant form does not really respond to the corticosteroid therapy or the immunosuppression which is used in AIH, and it may favor development of sepsis. So if you have any patient who is diagnosed with fulminant autoimmune hepatitis, they should be considered for early transplantation. So let's look at the ACLF presentation. This is the data from the ARC consortium and large database. Out of 2,800 patients, 2.9% patients fulfilled criteria of autoimmune hepatitis. The mean age of presentation was 42 years. And again, as I said earlier, predominant disease is in the females. Mean bilirubin was 18.6, and the MELD score was pretty high in this cohort of 20, the mean MELD score was 27.6. IgG was elevated in a lot of patients, and it was more than 1.1 times in almost 100% cases. Let's look at this. This is very important that 50% of the patients were seronegative. So again, suspicion of autoimmune hepatitis has to be high if all the viral markers are negative and they have a protracted course. Liver histology was available in 90% of these patients. 90% had moderate to severe interface activity, and 56% showed significant parenchymal necrosis, that is bridging and confluent necrosis. Again, cirrhosis was seen in around 40% of patients. Now, these patients were treated. 28 patients, that is 34% patients, received steroids and showed shorter intensive care unit stay and improved 90-day survival. So in ACLF, if AIH is diagnosed and if you give them steroid therapy, the outcome might be better as compared to patients who are not given any treatment. So how do you diagnose autoimmune hepatitis? There is no signature diagnostic feature of autoimmune hepatitis. Characteristic features supported by scoring system, which I will discuss in my subsequent slides. You need to have typical histology. You need to have clinical laboratory findings and presence of autoantibodies. And most important is that you should rule out other causes. So this is the revised autoimmune hepatitis score, and this was given way back in 1999. This score includes sex, enzyme levels, IgG and gamma globulin levels, autoantibodies, absence of viral markers, absence of drugs. There should be no alcohol intake, and HLA DR3 and DR4 has been associated with autoimmune hepatitis, presence of other autoimmune diseases, and typical histological features. And one of the criteria I said earlier is the response to treatment. If they respond completely, then you give 2 points. If they do not respond, then it is 3 points. So definitive diagnosis is if the score is more than 15, probable is 10 to 15. This is pre-treatment. And once you treat them, the definitive diagnosis is if it is more than 17, and probable is if it is between 12 to 17. But this score is cumbersome. It requires a lot of investigations, and sometimes you might not have all the tests which are required for diagnosis of autoimmune hepatitis in this table. So then came this simplified scoring system, and they modified the revised scoring system. And in this, they have included autoantibodies, immunoglobulins, histology, and viral markers. This is a simple score, and it is more commonly used now. In this, ANA positivity, 1:40 titers is given 1 mark. ANA 1:80 titers is given 2 points. Anti-LKM, if it is positive, 1:40 is given +2. And SLA, if it is positive, it is given +2. IgG levels, if it is more than upper limit of normal, +1. If it is more than 1.1 times the upper limit of normal, then +2. And if you have typical histology, that is interface hepatitis, compatible features +1 and typical features +2. The most important is that viral markers should be negative. And if they are negative, then you give +2. So the total score is, probable score is if it is more than 6, and definitive is if it is more than 7. Now, this score is very important. The caveats of this score is that it has low sensitivity, though it has higher specificity and accuracy than the comprehensive score, which I showed earlier. However, this score has not been prospectively evaluated and may miss the atypical cases, particularly the seronegative and the acute AIH patients where the autoantibodies can be negative. So let's compare the two scores. Comprehensive scoring system is very sensitive. Specificity is low as compared to the simplified scoring system where the sensitivity is less, but specificity is high. Diagnostic accuracy is also very high of this simplified score. The type of patients with atypical features are better evaluated because it's a comprehensive score and takes into account a lot of features. And patients with typical features are better evaluated by the simplified score. So as I said earlier, if there is acute presentation, fulminant presentation, or atypical presentation, then this simplified score might not be good for diagnosing of autoimmune hepatitis. Treatment can be applied before and after conventional corticosteroid therapy. So this comprehensive score can be applied before and after treatment, but simplified score, this cannot be used there. And treatment response can upgrade or downgrade the diagnosis in the comprehensive, but it is not there in simplified score. Validation by prospective studies, both these scores have not been validated much in prospective studies. So let's look at the autoantibodies which are present in type 1 AIH. ANA and asthma are two common autoantibodies which are usually done in clinical practice also. Other antibodies which can be positive are P-ANCA, soluble liver antigen, anti-actin antibodies. Anti-actin and SLA are highly specific for AIH and they are associated with severe liver disease. The other antibodies which are seen in autoimmune hepatitis, predominantly in type 2 AIH, includes LKM, LKM1 and LKM3, and LC1. And this is anti-liver cystosol type 1 antibody. Again, LC1 is associated with severe disease and progression to cirrhosis. So type 1 typically ANA and SMA, and type 2 typically LKM antibody. So different types have been described. Two common types are the type 1 and type 2 now, which is used in our clinical practice. Frequency, type 1 is more common in adults, type 2 in children. Age of presentation, peripubertal and adults, whereas it is usually seen in children. The mode of presentation, chronic symptoms are common. Ascites and GI bleeding are rare. Asymptomatic in 25 to 34%, acute in 25 to 75%. And acute onset is seen in around 40% in type 2 AIH. Acute liver failure is also more common and relapses are frequent. So this is severe disease, acute presentation more common. Let's look at the laboratory features and autoantibodies. Hypergammaglobulinemia, ANA, SMA, anti-LKM, anti-actin, and anti-actin and SLA are seen in type 1. IgG levels might not be elevated in type 2 AIH, but the characteristic antibodies, as I said earlier, are LKM, LC1, and anti-LKM3. Concurrent autoimmune diseases, autoimmune thyroiditis, RA, and IBD are more common, whereas autoimmune thyroiditis, diabetes, type 1 diabetes, and vitiligo are more common in type 2 AIH. Cirrhosis at presentation, 1/3 will present as cirrhosis, and in this type 2, at presentation it is rare, but progression to cirrhosis is faster in type 2 AIH because they tend to have a severe liver disease. Remission after drug withdrawal is possible in type 1 AIH since it is less severe as compared to type 2 AIH. In type 2, it is rare and it usually needs long-term immunosuppression. So you will not be able to withdraw immunosuppression in type 2 autoimmune hepatitis. What is the role of liver biopsy? It is very important to make the diagnosis of autoimmune hepatitis. There has to be a high clinical suspicion. Liver biopsy sometimes can be used to rule out other causes, and it also helps us to find the disease activity, and that is inflammation and fibrosis. So what are the typical findings on liver biopsy? This is interface hepatitis, that is portal inflammatory cells eroding through the limiting plate between the portal tract and the liver parenchyma. They can be spotty necrosis. And the classical infiltrate, that is, there is plasma cell, lymphoplasmacytic infiltrate, which is seen in autoimmune hepatitis. Sometimes they can be emperipolysis, which is engulfment of the lymphocytes by the hepatocytes, and acinar transformation of hepatocytes, which is known as rosette formation. And if it is severe autoimmune hepatitis, you see confluent necrosis, which can involve one or more than one zone. And you can also see bridging necrosis, which extends from one lobule to another. And as I said, 50% can develop nodules, and this is a typical cirrhotic nodule, which can be seen in along with this inflammatory infiltrate. So just to summarize the histological findings, classical is lymphoplasmacytic infiltrate of portal tracts. These are the high power images with interface hepatitis and rosetting and imperoplosis. So if you have these findings, then it is that then the diagnosis of autoimmune hepatitis can be easily made. The presentation, the histological findings in acute presentations are a little different. And in this, there is predominant lobular inflammation, and there is central lobular to confluent or bridging necrosis, and lymphoid aggregates can also be seen in around 30% of patients. Why is liver histology important? Because it correlates with the all-cause death or transplant. In this study, they showed that if the HAI is less than 3, the outcome is much better as compared to patients who have HAI more than 4. So key points for diagnosis of autoimmune hepatitis. Clinical judgment is of paramount importance. Suspicion has to be high, especially in patients who present with viral hepatitis-like illness and in which the viral markers are negative. Discussion between the histopathologist and the clinician. So biopsy interpretation is very important. I've shown you the histological features of autoimmune hepatitis. And sometimes the autoantibodies can be negative. Sometimes the histology might not be typical, but then a discussion between the histopathologist and the diagnosis can clinch the diagnosis at times where it is difficult. The diagnosis requires compatible histological findings, which is further supported by the following features. That is elevated serum transaminases, elevated serum IgG levels and or positive autoantibodies, and exclusion of other causes, viral, hereditary, metabolic, cholestatic, and drug-induced liver disease, which can resemble autoimmune hepatitis. What is the differential diagnosis? It's a kind of diagnosis of exclusion. You have to rule out all other causes of chronic hepatitis. Alcohol should be ruled out. Drug-induced liver injuries should be ruled out. A lot of our patients take CAM, complementary medicines. Some would be on herbal drugs. Some would be taking homeopathic medicines, and some would be taking concoction of so many other things. So drug-induced liver disease is very common, and sometimes drugs can precipitate autoimmune hepatitis as well. NASH is one of the common cause of liver disease, and AIH should be differentiated from NASH. 20% of the patients with non-alcoholic fatty liver disease can have autoantibodies positive. So if they have autoimmune antibodies positive, that doesn't mean that all patients, if there is anybody who has autoimmune antibody positive, doesn't mean that they have autoimmune hepatitis. You have to see the patient in totality. You have to look at the other autoimmune liver diseases, primary biliary cirrhosis, primary sclerosing cholangitis, and IgG4 associated cholangitis can also sometimes have features similar to autoimmune hepatitis. Other differential diagnosis includes granulomatous hepatitis, hemochromatosis, alpha-1 antitrypsin deficiency, Wilson disease, SLE, and celiac disease, which have typical findings, clinical as well as the laboratory. So let's look at the diagnostic algorithm for patient with suspected AIH. Look at the autoantibodies, ANA, SMA, LKM. LKM is more common in pediatric population. If it is negative and the suspicion of autoimmune hepatitis is high, look at the extended panel, that is soluble liver antigen. P-ANCA can also be done, TTG and AMA to rule out other causes. And if it is SLE positive, it is AIH. If it is P-ANCA positive and there's typical histology, again, it is AIH. And a small proportion, as I said, 10 to 15% would be autoantibody negative AIH, which will be picked up on histology. The other group is, if you have any of these positive TTG, then it is celiac disease. And AMA positive, that means it is primary biliary cirrhosis. And I'm not discussing the overlap syndromes where you can have features of autoimmune hepatitis with the primary cholestatic liver disease like PBC, or you can have AIH with other primary cholestatic disease, which is primary sclerosing cholangitis. All patients who have, in which there is a suspicion of AIH need a liver biopsy. Interface hepatitis is classically seen. And if there is a lymphoplasmacytic infiltrate, then you can straightaway label them as autoimmune hepatitis. If there is evidence of bile duct injury or loss, then it's an overlap syndrome, which can be an overlap with PBC or PSC. And if you have autoantibodies and if you have fat in the liver, then there can be a combination of AIH with non-alcoholic fatty liver disease, or it can just be non-alcoholic steatohepatitis. So this is the diagnostic algorithm for autoimmune hepatitis. So let's go to the treatment part. This is what the American Association of Study of Liver Disease recommend. If there is autoimmune hepatitis, these patients can be started on steroids, prednisolone 20 to 40 milligrams, In pediatric population, it is weight-based, 1 to 2 milligram per kg. A small group also suggests that you can use budesonide, which is 9 milligram daily. And you should check the TPMT levels. And after 2 weeks, you can add azathioprine. The dose is 50 to 150 milligrams per day. And laboratory testing should be done every 1 to 2 weeks. Assess response by 4 to 8 weeks. Biochemical response is there. If there is a biochemical response, then taper prednisolone to 5 to 10 milligrams daily. Budesonide, bring it down to 3 milligrams daily. And this can be done over a period of next 6 months. Maintain azathioprine, and laboratory testing can be done every 2 to 4 weeks. Look at the biochemical response, reevaluate diagnosis if there is no biochemical response, and consider second-line drugs, which I will discuss in my subsequent slides. Once biochemical remission is achieved, laboratory testing should be done every 3 to 4 months. May attempt a steroid withdrawal while continuing azathioprine. And after complete biochemical remission for 2 years, laboratory testing can be done every 4 to 6 months. And consider immunosuppression withdrawal if appropriate, and if you are able to do biopsy, and if you feel that patient has been in a remission for at least a duration of 2 to 3 years. In patients with AIH and cirrhosis, steroids, do not use budesonide because there's a high first-pass metabolism. Can be started on prednisolone 20 to 40 milligrams. Azathioprine should not be used in decompensated cirrhosis. In compensated cirrhosis, look at the TPMT levels, and after 2 weeks, you can add azathioprine if there is a response, and dose is same 50 to 150 milligrams, which is stepped up over a period of time. Laboratory testing should be done every 1 to 2 weeks. Response is similar, tested similar to AIH only, and then subsequently you can taper the drugs if there is good response to treatment. If there is no response, then you should consider second-line drugs. How do you manage acute severe AIH? Do not use budesonide. Do not use azathioprine. Prednisolone is a drug of choice. High-dose prednisolone can be used. In pediatric population, 2 milligram per kg body weight. Even IV steroid methylprednisolone has been used in acute severe AIH. And laboratory testing has to be done every 12 to 24 hours. Assess response by 7 to 14 days. If there is biochemical response, cautiously reduce prednisolone. Consider azathioprine after cholestasis is resolved. Check TPMT levels also. And laboratory testing every 1 to 2 weeks. If there is no biochemical response, reevaluate diagnosis. Consider second-line drugs. Initiate transplant evaluation. And if the patient develops hepatic encephalopathy, then this is the fulminant form of AIH. They should be taken up for urgent transplantation. Once biochemical remission is achieved, laboratory testing should be done every 3 to 4 months, and use lowest immunosuppression doses to maintain remission. Do not withdraw immunosuppression in acute severe AIH because they tend to relapse. So let's look at the long-term outcomes of patients of autoimmune hepatitis. A large retrospective study, and this was from 1971 to 2007 in United Kingdom. Median follow-up of 9.4 years. Total patients 245, and started on steroids 209. Patients treated with steroids at any stage was 224, and patient receiving azathioprine for more than 1 month was in 188 patients. And alternate immunosuppression, that is second-line drugs, were used in 49 patients. So typically 50% presented in the chronic form, acute presentation in 34, and 4 had insidious onset. So out of 245 patients, 11 were transplanted, 70 died, 15 were lost to follow-up, and 149 were alive by the end of this study. Cirrhosis development at 10 years in 12%, at 20 years in 34%. And liver disease-related survival rate at 10 years was pretty good, 91%, and at 20 years it was 70%. What were the variables associated with death and transplantation? Decompensation at presentation, cirrhosis, number of lapses per decade, and failure to normalize serum ALT levels within 1 year, and non-treatment with azathioprine. So patients who were not treated with azathioprine, that means they had severe disease, had poor response, and had higher death, and went on to get transplanted. So let's look at the difficult to treat AIH, which is not responding to the first-line drugs. So this can be divided in 2 groups, one which is treatment intolerant, and the second is incomplete response and non-responders. So what are the endpoints of treatment in autoimmune hepatitis? This is a recent paper and which is very nicely demonstrated. Intolerance to treatment is any adverse event possibly related to treatment as assessed by the treating physician leading to potential discontinuation of the drug. And non-responses if there is less than 50% reduction in the AST/ALT levels at 4 weeks. And complete biochemical remission is if the transaminases become normal and IgG becomes normal at 6 months. If they do not become normal, then it is labeled as insufficient response. And remission is if you can demonstrate that there is improvement in the histology and HAI score less than 4 out of 18. Okay, so remission is seen in around 65%, that is normalization of AST/ALT. Incomplete response in 15%. Treatment failure is seen in around 9%, and drug toxicity is seen in around 15%. So even in patients who have remission, if treatment is stopped, majority will relapse. So be very careful when you're planning to withdraw immunosuppression in patients with autoimmune hepatitis. And sustained remission is seen in around 21% in patients who relapse. So what are the second and third line drugs for autoimmune hepatitis? CNIs, which includes tacrolimus and cyclosporin, mycophenolate mofetil, which the dose is around 20 to 40 milligram per kg per day, mTOR inhibitors, which includes sirolimus and everolimus. 6-mercaptopurine has also been used, and there is some new data which is coming up on drugs like rituximab and B-cell activating factors. So a lot of drugs which are available and can be used as second line drugs, and patients who do not respond to the first line treatment should be put on second line drugs. So let's look at the data. This is a large study from Switzerland and a retrospective single center analysis. In this study, 144 patients with autoimmune hepatitis were taken, and 35% patients received MMF. 80% received MMF due to first line treatment intolerance, and 20% received this due to insufficient response to the first line treatment. A remission with MMF monotherapy was seen in 81% in the intolerant group versus 30% in the insufficient response group. And patients in insufficient response group required a longer time and additional doses of prednisolone or switched to third line drugs to achieve remission. So this is a significant difference between the two. Large data on the use of mycophenolate and tacrolimus as a second line therapy in patients with autoimmune hepatitis. In this, 2,200 autoimmune patients were included. Second line therapy was given in 302 patients, and MMF was given in 121 patients, tacrolimus in 80 patients. The reasons for switching therapy to MMF or tacrolimus was ASA intolerance, which was seen in around 38%, steroid side effects in 15%, and non-response to standard therapy in 46% of patients. Let's look at the response. Complete response in 2/3 patients. So that is 1/3 of the patients will not respond to the second line drugs also. 69% in MMF and 72% in tacrolimus group. The response was better in patients who were intolerant as compared to patients who did not respond to the first line drugs. So if you have side effects to the first line therapy, the response to second line drugs is much better. If they are not responding to the first line therapy, then the response to treatment with second and third line drugs is also not very good. So this is a systematic review of mycophenolate mofetil as a second line therapy. Total 12 studies are available. Follow-up period is of 34 months, response rate of 58%, adverse event in 15%, and response rate among intolerant to standard medical therapy is 0.82 versus 0.32 in non-responders. Let's look at the other drugs, CNIs. Again, a systematic review. 20 studies from literature and 9 Dutch patients were included. Total patients 279, cyclosporin given in 59 and tacrolimus in 219 patients. CNI remission rate in patients with insufficient response to first-line treatment was 53%. And patients who were intolerant to first-line drugs, it was 67%. And remission rate when CNI was used as a second-line treatment was 52%, and it dropped down significantly to 26% if they were used as a third-line treatment. There are certain other drugs which have been used as second-line drugs, and this is the data on everolimus. Small data, 7 patients, non-responder to first or second line drugs, given everolimus, and there was a reduction of transaminases within 2 weeks. And after 3 to 5 months, 3 patients had normal ALT and 4 patients had partial response. Sustained remission after 1 year was observed only in 3 patients. Use of sirolimus in the treatment of refractory autoimmune hepatitis. Small data again, longitudinal follow-up study. 5 subjects with steroid refractory autoimmune hepatitis were treated with sirolimus. Response was defined as a sustained more than 50% fall in ALT levels, which was achieved in 4 out of 5 patients. Complete response was, however, achieved in only 2 out of 5 patients. Very interesting data on this use of rituximab, and this is a recent paper. 22 patients who were intolerant to the first line and second line and third line drugs. 22 patients who were either given prednisolone, azathioprine, mycophenolate mofetil, tacrolimus, cyclosporin, budesonide, sirolimus, or 6-MP. And they gave 2 doses of rituximab. Very good response at 2 years, 71% complete response. And look at the AST and ALT levels, significant reduction in AST ALT levels and reduction in the immunoglobulin levels also. And remission rates were much higher in which it was used, rituximab was used as compared to the other drugs. So let me just show you our data from PGI. This is the real world experience from our hospital. And in this patient, we included 275 patients. These are all biopsy proven autoimmune hepatitis patients. And this was a retrospective study from June 2008 to April 2021. The spectrum of autoimmune liver disease included autoimmune hepatitis in 58% patients, AIH with PSC in 7%, AIH with PBC in 24%. A lone PBC was seen in around 5% and PSC in around 6%. In AIH, the acute presentation was seen in around 10%. Fulminant, this included fulminant and acute presentation. And acute and chronic liver failure was seen in around 4%. Chronic hepatitis in 30%. And majority of our patients also presented with cirrhosis, thereby suggesting that most of the patients present late to a tertiary care hospital. And usually these cases are missed initially as viral hepatitis in most of the peripheral centers. Let's look at the response to treatment. Pretty good response to treatment, and fibrosis stage and non-attainment of complete response was one of the markers for progression of disease and non-response to treatment. So out of 161 patients with autoimmune hepatitis, 93% received immunosuppression and all received prednisolone. Azathioprine could be given to 124 patients only. And complete biochemical response was observed in 62%, partial response in 24%, and no response in 10%. 4 patients received mycophenolate mofetil in patients who do not respond to standard immunosuppression. 1 of them had a complete response, and 2 patients had a partial response to MMF. 2 patients received tacrolimus. However, none of these patients achieved partial or complete response. So let me conclude here. Autoimmune hepatitis is a complex and heterogeneous disease. The presentation is variable. There is a high index of suspicion which has to be kept for diagnosis. Clinical judgment is of paramount importance. Response to treatment is good if picked up early, and individualized treatment protocols are the key, where patients do not respond to the first line drugs, and I've shown you the second and third line drugs which can be used in these patients. Thank you very much for your patience. I have a few questions for the postgraduate students if they have joined. Can I ask those multiple choice questions? So I think I've concluded my presentation.
Can you hear me, Dr. Taneja?
Yeah, it's audible.
Yeah. Thank you, Dr. Taneja. And I think the topic was very, very exhaustively covered. Thank you for that. And I'm sure the PGs who are attending would have grasped everything and taken down notes. I'm hoping that they will ask you a lot of questions in the chat box, if that is the format. But shall I?
Yeah, I can take the questions, and I have 5 questions for the postgraduates if they want to ask the MCQ question, want to answer the MCQ questions. Should I ask those 5 questions and
maybe
how active they have been through the presentation? So the first question is, AIH is characterized by hypergammaglobulinemia, autoantibodies, certain HLA antigens, interface hepatitis on histology, and appropriate response to immunosuppression, or all the above. I think Dr. Ashish, you will get the response in the chat box. Okay, the second question is, what are the autoantibodies which are seen in autoimmune hepatitis? They include ANA, asthma, LKM, and anti-mitochondrial antibody, or all the above. So autoantibodies seen in autoimmune hepatitis include ANA, asthma, LKM, or AMA, or all the above. And the third question is, simplified scoring system includes autoantibodies, IgG level, histology, absence of viral markers, and all the above. Simplified scoring system includes autoantibodies, IgG level, histology, absence of viral markers, and all the above. And fifth question is, the first-line treatment of AIH is prednisolone, azathioprine, mycophenolate, tacrolimus, or both A and B. And the last is, second-line treatment of AIH includes mycophenolate, tacrolimus, budesonide, and all the above. So that's all from my side. I can take the questions.
Thanks, Dr. Taneja. I will encourage the students and the postgraduates who have joined in to put their questions in the chat box. And we can go back to Dr. Taneja's questions once they have asked their questions as well, if need be. Let me start with few questions, Dr. Taneja, if it is okay.
Yeah.
Can you, because you would have seen a lot of autoimmune hepatitis in coming to your outpatient clinic, what is a typical patient which you would say most common presentation of autoimmune hepatitis in your outpatient clinic?
So most of these patients present with non-specific symptoms or a chronic hepatitis-like picture. So some of them would give history of joint pains, arthralgia, non-specific symptoms, fatigue. And when you evaluate them, they would have deranged LFTs, and they would, on further workup, turn out to be autoimmune hepatitis. The other presentation is typically presentation with fluctuating jaundice. So they have this episodes of jaundice, which has been going on for years together, fluctuating. It goes up, bilirubin goes up, enzymes go up. They're diagnosed as acute viral hepatitis. Subsequently, it settles down, and over a period of, again, they have this second episode, third episode. And once they're completely worked up over a period of time, then they are diagnosed with autoimmune hepatitis. So two typical presentations. One is obviously chronic hepatitis, and second is asymptomatic presentation. This is more common. Being a tertiary care referral hospital, we tend to get a lot of patients with cirrhosis as the first presentation. I think because they are referred for evaluation and for cirrhosis, and once we are evaluating for cirrhosis, and retrospectively they turn out to be autoimmune hepatitis.
So when you say cirrhosis, Dr. Taneja, is it on the biopsy cirrhosis, or the person is having portal hypertension and complications?
Yeah, so both, I would say. A lot of these patients have portal hypertension, and if you do biopsy, they have typical features of cirrhosis, so nodule formation, and you also have non-invasive markers which you can do in such patients. So if you do a fibroscan, this would be elevated. If you do an endoscopy, then obviously you sometimes find varices. And in our study also, we've seen that 1/3 of these patients of cirrhosis had either previous history of decompensation or they presented with decompensation. So that's a huge number.
So I think what you're saying is it can present as almost any syndrome.
Yes.
Of liver disease. It can come as acute illness or a chronic illness or a cirrhotic or end-stage illness as well. So if I ask you one more time, is there a typical patient that you see as a sick acute liver failure patient? How do you see acute liver failure presenting?
So this is a very important question. So most of the time, you would not pick up fulminant autoimmune hepatitis. in our clinical setting, most of the patients are usually labeled as seronegative acute viral hepatitis. I think the issue is that you're not able to do liver biopsies in such patients. And if you don't do a liver biopsy, then the diagnosis of acute AIH is very difficult. Even on biopsy, it might be very difficult at times. You need a pathologist who's well trained to look at those slides. As I have shown in my slides, the typical autoimmune markers might be negative. IgG might not be elevated. But then there are certain clues on biopsy which might help. So histology is very important. So centrizonal necrosis or submassive necrosis. And if you have AST more than ALT at times, if you have other autoimmune diseases, young female, viral markers are negative and all other workup is negative, then suspicion should be kept for autoimmune hepatitis also.
Thanks, Dr. Taneja. So that brings me to the next question that I had for you is what if at all the typical patient where we are suspecting autoimmune hepatitis, what are the initial investigations that we should send or a clinician who is sitting in a say secondary level center should send these initial investigations to suspect more strongly?
Yeah. So I think this is again a very important clinical practical question. So once you do LFTs and if the AST-ALT is elevated, then you have to evaluate for that AST-ALT. And if there's a typical young female with history of autoimmune disease like thyroiditis, vitiligo, type 1 diabetes, previous history of jaundice, and if you see that she's been complaining of non-specific symptoms like fatigue, some joint pains, anorexia, and menstrual abnormalities, then always think of autoimmune disease in that patient. And in such a patient, autoantibodies should be tested, and along with IgG levels, if they are elevated, then we should subject them to biopsy and see whether they have autoimmune hepatitis on biopsy. So anybody who just comes with first-time presentation with raised enzymes, I don't think so you should do such thorough evaluation. So if there is a persistently raised enzymes for 3 to 6 months, then you need to evaluate them.
Oh, that was very helpful, Dr. Taneja. And what do you think if suppose a person with hepatitis A or E and on evaluation turns out to be ANA positive, do all patients with autoantibody positive require detailed evaluation and treatment for autoimmune hepatitis?
So that's again a very important question. So as I said, these are autoantibodies and they can be an epiphenomenon, especially in acute viral hepatitis and with drug-induced liver injury also. So if there is a patient who is improving, and if it is a first episode, then I would suggest that you don't need to evaluate that person further. If there is no improvement or if there is persistent derangement of liver functions, then I think subsequently they would need evaluation and biopsy if the LFT has not improved. So there are cases where autoimmune hepatitis has been triggered by a viral illness or by drug-induced liver injury also. So there are cases which you will pick up on biopsy only.
That was very helpful, Dr. Taneja. Another question that I had, because I was taking notes, it was a very informative lecture. Sorry for keeping on asking more and more questions. Do all patients of autoimmune hepatitis require immunosuppression? Is there a group where we can say maybe autoimmune hepatitis, but may not require immunosuppression?
So if you look at the latest data now, whatever studies which are coming up, even in the asymptomatic group, if there is histological evidence of activity, they should be treated. Because over a period of time, they tend to progress to chronic liver disease, cirrhosis, and obviously they can go on to develop decomposition and end-stage liver disease also. So recent data also suggests that if histological evidence of activity is there, they should be put on immunosuppression.
So if there is histology for activity, they should be immunosuppressed. But just because autoantibody is positive, it may not always require treatment.
Yeah,
so you are basing your decision on histology and giving a lot of importance to histology.
Autoimmune hepatitis is a histological diagnosis. Okay. We have to remember this. You need to do biopsy in all your patients to make diagnosis of autoimmune hepatitis. Just based on autoantibodies, you can't make diagnosis of AIH.
So I understand it's a constellation.
Yeah, constellation. So 20% would be positive in fatty liver disease also, antibodies. So that doesn't mean that they have autoimmune hepatitis.
So it's a constellation of findings and both clinical, laboratory, and histology, which makes a diagnosis of autoimmune hepatitis. So if the person is on steroids, Dr. Taneja, and he has cirrhosis to start with, do you think cirrhosis can regress? All of us will like to know that.
So advanced fibrosis and compensated cirrhosis, there is some data that it might reverse. Okay, and especially in one is autoimmune hepatitis, second is Hep B with antivirals, and Hep C also, and Budd-Chiari syndrome. So 4 conditions where it might reverse also. So I think with good treatment, if they come closely followed up, and if you do non-invasive, most of us would do non-invasive markers in these patients. So if you look at the FibroScan values in autoimmune hepatitis, they are initially high. It could be because of inflammation and fibrosis both, but over a period of time, it tends to regress also. There is data to show that.
So you are giving us all hope that even cirrhosis may not be end-stage liver disease. They may be treatable.
So advanced fibrosis and compensated, yes. Once it is decompensated, then obviously it doesn't work.
So at a certain stage of illness, it may still be reversible, and these patients may not respond to immunosuppression and may be going down the transplant route is what you suggest. That brings us to the next question, because I'm not sure how many of us will be in secondary and tertiary level. When do you suggest a patient should be referred to a higher center?
High center. So if there is a suspicion of autoimmune hepatitis and if the patient needs a liver biopsy, they should be referred to a center where liver biopsy facilities are available. I don't recommend giving treatment just based on autoantibodies or LFT pattern. So because it's it's an immunosuppressive medication which you're using, it has to be used on long-term basis. And without liver biopsy, I don't recommend giving treatment for autoimmune hepatitis, except in special situations where biopsy cannot be done. So that 2 special situations is, one is elderly patients, sometimes, where biopsy might not be possible and patient might be very apprehensive for liver biopsy. And second is sometimes during pregnancy, there is a flare of autoimmune hepatitis where you might not do biopsy and give them immunosuppression.
That was thanks for clarifying that. Taneja, if we decide to stop steroids, you said you have to be careful because relapse is almost quite high percentage. So what are the points that we have to take care when we are stopping immunosuppression? And how long should we continue before even thinking about it?
In autoimmune hepatitis, usually a small dose of steroid is required on a long-term basis. Complete withdrawal of steroid might be possible if there is no advanced fibrosis, no cirrhosis, complete biochemical remission, if histology also shows remission. And usually what people have seen is that if the patient has been in complete remission for 2 years, then you can try and think of withdrawing the immunosuppression. So 2 years is minimum where you need to continue immunosuppression, and maybe a minimum dose of steroid and azathioprine. And then you can just start thinking of withdrawing immunosuppression and keep them to a minimum dose of azathioprine.
I am running towards the end of my questions. I just had a sort of a clinical question. The second line agents, I think first line agent of steroid plus minus azathioprine, they tend to work in majority of patients. And if we are going to second line agent, is generally not a good scene. So when we start mycophenolate and calcineurin inhibitors, do you have any levels that you can monitor in these patients, or it is not enough data to suggest that?
I think there's not enough data, especially, mycophenolate levels are not available everywhere. And even in transplant setting, mycophenolate levels are not being done. But you tend to look at this CBC, that is the complete blood count. And if they have development of thrombocytopenia or cytopenias, then you tend to either reduce the dose, and if they're not tolerating, then you need to stop mycophenolate mocktail. In tacrolimus, there are studies where people have targeted a level of 5 to 8. And if this level is achieved, then the response is shade better as compared to the lower levels. So if you're using tacrolimus, then levels of 5 to 8 are good enough for AIH patients getting into remission.
Thank you, Dr. Taneja. I think that was a very useful topic, and I'm pretty sure the postgraduates here would have learned a lot. I don't have any questions in the chat box unless somebody wants to ask the questions. Please raise your hand and I will, you can unmute the mic, I think.
So I think one important group is the acute and chronic liver failure, which we all are seeing now. And this is because the index of suspicion has gone up and we are doing more and more of liver biopsies. Earlier, we were doing only percutaneous liver biopsies. And since these patients are coagulopathic, we were not able to do liver biopsies. Now, with the advent of transjugular liver biopsy, we are doing more of biopsies in such patients who even have coagulopathy. And we are picking more and more cases of acute and chronic liver failure. And as I showed that ARC data also, the response to treatment is reasonable, I would say, not very good, reasonable. And in that study also, they showed that the ICU stay is less and the 90-day survival is better as compared to patients who are not treated at all. So two groups very, very important, which I think we usually tend to miss is one is the ACLF group and the second is the acute group. And fulminant, I don't think so. I think Ashish, you would agree that we don't really pick up the fulminant group because most of them are very sick and most of them are labeled as seronegative acute viral hepatitis only.
So no, I'll agree with Dr. Taneja. I think there are no further questions, looks like, and you have been very clear in your presentations, Dr. Taneja. Can I give it back to the host team?
Yes, sir. So we had a very beautiful discussion on autoimmune hepatitis. And moving ahead, I would like to invite Dr. Ajay Kumar Sood, sir, the Deputy Secretary of NAMS, to kindly deliver the word of thanks.
Thank you so much. Indeed, it is my great pleasure to thank both the experts of this evening for making this session so interesting and interactive for the students. I'm sure that our MD students and other postgraduate students who are attending this session, they might have found it very useful from examination point of view as well as for their clinical practice. So, our great thanks to the speaker for this evening, Dr. Sunil Taneja, sir, for making this presentation very comprehensive and supporting with a lot of empirical evidence and studies. And we look forward for your support in future also. Our special thanks to Professor Ashish Goel for kindly agreeing to chair this session and steering the discussion in such a nice way. And this discussion, again, I think will be very, very useful for our students. And again, you agreed for chairing this session at a very short notice, despite your very busy schedule. So we are really grateful to you for your support, and we look forward for your blessing in future also. As our PG students know that this is the last session of the series with the theme on liver problem. Once again, I would like to place on record the support which we have received from the Chief Coordinator for this series, Professor Ajay D'Souza, who has identified the topics as well as identified the best speaker as well as the chairperson. So once again, on behalf of the National Board of Examination, we are grateful to Professor D'Souza and the entire team. So I will again like to, once again, I'd like to place on records the speakers which have contributed for this series, Dr. Sahaj Rathi, Dr. Nipun Verma sir, Dr. Madhumita Prem Kumar, Dr. Arka De, and the present session which we have just finished by Dr. Sunil Taneja. We had equally important chairpersons who moderated as well conducted a session. Their names are Professor Manoj Kumar, Professor C. Appan sir, Professor Akhosh Shukla, Professor Shalimar, Professor Rakhi Maiwal, and this session we are really grateful to Professor Ashish Goel sir. Thank you so much for your support and blessing to the academy. Now, some information for the students who are attending this session. With this, we are concluding the series on hepatic disorder, and the next series which we are going to have from 1st of June, we are going to have 3 sessions on hematological disorder. So the first session in that series is approach to anemia, which is scheduled on 1st of June. And the second session is on 3rd of June, where we are going to have a very interesting topic, diagnosis and management of VTE. And the third session in the series is scheduled for 6th of June, which is the approach to thrombocytopenia. And all these details of the program, Zoom link, we have circulated to the students. So once again, I would like to appeal to all the students to please inform this to your colleagues so that they get the benefit of having interaction with the best speaker in the country. So with this, once again, I would like to thank my colleague here, Dr. Chippy, who has been helping us from the very beginning for acting as a moderator and conducting the session, and our IT team, comprising of Mr. Ravi and Mr. Anil Kumar. So once again, thanks to all of you and good night. Thank you very much.
Thank you very much.
I declare the session as closed. Thank you.